Thank you, Madam Chair, members of the committee. Dan Kim, Chief Deputy Director of Operations. You asked us to identify some of the funding trends since fiscal year 07-08. So we've provided a chart, and I can go over that with you. We'll talk about what some of the funding reductions were, where they were, and then Kathy Billingsley will speak to the impacts of those cuts. Page 1 of your chart will show you in blue the amount of funds we had in fiscal year 07-08, broken out by different types of program areas and funding sources. If you compare 07-08 to fiscal year 13-14, which is an apples-to-apples comparison, you'll see that the funding overall hasn't really changed much in terms of total funding. We've only had like a $150 million increase overall in that 7-year period. But what's very important to note in page 1 is the different mix of funding that we have. We see significant increases in certain programs and decreases in others. So, for example, you'll see in the WIC program, we've seen about $250 million increase in that one program. That's federal funds dedicated for a particular purpose. In the drinking water program, we've seen a slight increase in funding, and that's largely due to federal funds. But it's been largely washed there. Other federal funds besides those for the WIC program or for the drinking water program, overall we've seen a slight decrease in funds in those programs. So that means for the department as a whole, you see programs that are federally funded like the Ryan White CARE Act funding has gone up for the department, but a lot of federal funds for communicable diseases has gone down in terms of federal funds. Special funds and reimbursements have gone up over the past 7 years. A large part of that is with our L&C program and some other special funds. But you'll note the general fund has decreased significantly over that time. It's been about a 72% reduction in general fund, from $391 million to $111 million during that period. Now, page 2 goes into a bit more detail about where the general fund reductions have been in. You'll note that I did not list the reduction in ADAP funding or general fund for ADAP because all of that program, while we no longer have general fund in that, is fully funded with federal funds and other fund sources. But you'll see to your left the HIV prevention surveillance programs have seen a significant decrease in general fund support. You'll also see that our infectious disease programs like STD control, TB control, our labs, our vector-borne disease control, those programs have also seen a significant decrease. Our maternal, child, and adolescent health program has seen a major decrease as well. It's been decreased by roughly 94%, from somewhere around $50 million. It's seen about a $50 million decrease in that 8-year period. Emergency preparedness has seen about a 41% general fund reduction, and chronic disease programs have seen their general fund support decrease by almost half. Also, environmental health has seen a 44% general fund reduction, and other programs within the department have seen about 73% general fund reduction overall. With that, I will turn to Kathy Billingsley, who will speak to some of the impacts.
Good afternoon. I'm Kathleen Billingsley. I'm the Chief Deputy Director of Policy and Programs at the Department of Public Health. And as requested, we would like to provide you with a few examples of how the funding reductions have impacted the Department of Health's programs. There are other examples, but these items will provide you with a good idea of the impact. Other programs such as asthma, oral health, and others are not included in this particular summary. The first one I'd like to touch on is infectious disease. CDPH has seen a reduction of more than $20 million, which is over 20%, in combined state and federal funds for communicable disease, infectious disease, STD, and TB control since fiscal year 07-08. We have lost 23 positions just in fiscal year 12-13. As a result, these reductions have limited our infectious disease laboratory and surveillance capacity. Our dedicated staff can still respond quickly to a single significant outbreak, but when we do, we must halt our routine surveillance and disease control activities. CDPH cannot respond to multiple large breakouts simultaneously. We do not have full capacity for emergency response to new threats similar to West Nile virus or a pandemic flu, and lack the resources to test multiple drug-resistant organisms. We don't have the laboratory capacity to test for fungal diseases like valley fever. State and federal funding cuts have weakened our efforts to control hepatitis, TB, and STDs. For example, with viral hepatitis, 3.2 million people in the U.S. have hepatitis C, which now is responsible for more deaths than HIV. Currently, CDPH has funding for one position to respond to this growing problem. For TB control, the loss of CDC funding in 2013 for genotyping means that we cannot track outbreaks as quickly and as effectively, which may lead to greater numbers of TB cases. The local health department lab capacity. In that area, the loss of general fund for local lab training, surveillance, and operations has weakened the state's overall responsiveness to infectious disease control. I'd like to return to a topic that you have been discussing, I think, very thoroughly and effectively today, which is HIV/AIDS care and prevention. There's been a loss of $162 million general fund reductions since 07-08. Of this amount, $91 million, or 56%, was for ADAP. ADAP, however, is fully funded now as a result of increased federal funds, rebate funds, and lower caseloads with the transition to LIP, Medi-Cal, and Covered California. But $71 million in general fund reduction to HIV, education and prevention, early intervention and surveillance, and other services have been impacted. For instance, when the HIV prevention funds were eliminated, it affected 43 local health departments. State and federal funding for syringe exchange programs was eliminated. Funding for HIV test counselors and the AIDS hotlines were cut. Non-medical HIV testing dropped from 92,000 to 40 tests per year, cutting in half the number of new HIV infections identified. HIV surveillance eliminated funding for special epi studies, hindering our ability to track at-risk populations and trends in the epidemic. The loss of HIV prevention and surveillance funds has likely impacted the infection rate and raised medical treatment costs. As noted earlier, a recent CDC report estimated that the reduction in HIV prevention efforts in 59 counties in California, excluding LA and San Francisco, resulted in an additional 55 persons being infected with HIV annually. Now I'd like to turn to maternal, child, and adolescent health. The total MCH local assistance budget, which is Title V General Fund and Title 19, decreased by $74.4 million, or 63%, between fiscal year 07-08 and fiscal year 14-15. In 07-08, the maternal and child health local assistance included $45 million general fund. Today, there is no general fund. The local health departments have leveraged the general fund, had been able to leverage the general fund to bring down federal Title 19 funds. With this loss of general fund, local health departments have drawn down $20 million less in Title 19 funds than they did before. Over the last 8 years, with the Adolescent Family Life Program, that program has been reduced by 75%, so over 11,000 fewer participants are served annually, and 9 counties eliminated their programs. For Black infant health, it was reduced by 29%, with almost 6,000 fewer participants served annually, and 2 counties eliminated their programs, and 55 local Black infant health positions were eliminated. For overall, the local maternal and child health program was reduced by 49%. Despite these significant state and federal funding reductions, the maternal and child health remains a leader nationally for its research, toolkits, and innovative strategies. We have received an A grade from the March of Dimes for our premature birth report card. Infant mortality is at a record low of 4.5 per 1,000 live births in 2012, which is the latest year for reporting, and we have a record low teen birth rate, almost half the rate it was in the year 2000. The eliminated funds, we've also been unable to, now I turn to, emergency preparedness. The elimination of general funds have meant that we can no longer store and manage some of our surge assets. In order to mitigate, we distribute many of these assets to the local health departments. We established public partnerships to secure storage for our surge assets, and we have also redirected our hospital preparedness program funds. The HPP fund, which is Hospital Preparedness Fund, now expects this year to be cut by 30 to 40%, which will require us to cut or eliminate funds to provide technical assistance to hospitals, clinics, and long-term care facilities. This has reduced our ability to address pandemic flu preparedness, and there's been a total cut from $16 million to $4.9 million. And this has also, of course, affected the local health departments. We've identified for you some of the major funding reductions to our Department of Public Health programs. However, this list does not reflect many other smaller programs that have faced general fund reductions over the past 8 years. These programs include Alzheimer's research and oral health disease prevention. We've also seen federal and grant fund reduced and eliminated for other programs to include the Asthma Public Health Initiative. We've been notified by the CDC that the Community Transformation Grant will be eliminated. While these funds did not flow directly to the Department of Public Health, they provided upwards to $20 million in public health prevention funds directly to the local health departments and nonprofits that we work with. I have been with the department since 2006, came from the private sector, and I have to really commend so many people in the Department of Public Health. They have demonstrated during this 10-year period an incredible commitment. They've been innovative, they've been resilient. Do they complain, and do they wish that they could do more? Absolutely. There's very few people in government who don't wish we could always do more. But for me, it's been a very proud period of time to see people rebound and try to do as many things as they can do. Thank you.
Thank you. Okay, any other comments from LAO or anyone from finance? Okay. Any comments, questions?
Well, only a thought that I'm sure folks who have been watching the Senate and Assembly Budget Committee for 14 years have heard me say many times. But it's so hard to prioritize the actions that prevent things from happening because you don't see what doesn't happen. So when you go to a restaurant and you drink some water and you don't get sick, you don't think, oh, somebody made that happen. You just take it for granted that doesn't happen. When somebody doesn't get HIV or doesn't start smoking, well, how can you measure that didn't happen? And so that's part of the problem with public health we've always had, is getting it prioritized. And it's, I leaned over to my colleague here and said, there's a lot of bad decisions that we've made in terms of having to survive this budget crisis, but in terms of investment, it just seems like public health is one of the dumbest places for us to skimp and not spend the money, because you're just going to pay for it, aside from all the humanitarian concerns, which many of the programs we've got have. But in this case, it's so obvious, and there's a direct link from point A to point B, but again, we don't measure it very easily because until, I guess, those things begin to happen because we haven't funded them.
I wanted to ask about the chart and just confirm that the two charts don't include funding or the loss of funding for the early mental health screening program. Is that right?
Correct. It does not include that. Those do not flow through our department.
Which was about $15 million, if I recall. And so if we put that in your general fund cuts on page 1, we'd actually and looked at it as part of public health, we'd actually have lost more than 75% of the general fund funding over the last few years. So it's even more stark. I mean, listening to the description of what's not getting funded now is stark enough, but to think it's even more difficult than that. And I would certainly echo the comments of Mr. Chesbrough with respect to the disinvestment in public health and the consequences of that over time, which obviously is a reduced level of safety and health in the community and an overall much greater expenditure of money to address the circumstances in the long run. So as one member of this subcommittee, I'm certainly very interested in looking at reinvestment in public health. The chair of our budget committee has talked about from time to time in the course of the start of this year strategic reinvestment. This is for a lot of us what strategic reinvestment means. It means reinvesting in public health, which has taken such an enormous hit. And I don't want to, I have a couple program-specific remarks after the public testimony, but I don't want the point that Bruce Palmer made to be lost, which is when we finally came to a conclusion on the Medi-Cal expansion funding allotment and how that treated counties, it cost the counties with respect to their public health programs as well as the CMISP program. And to think that all we were doing in that formula was offsetting the cost of treating the medically indigent, I think was to misunderstand the consequences. Now we'll be able to see some of this as time goes on, but there's no question that here in Sacramento County, just as one example, the County Department of Public Health has certainly struggled mightily in the last few years, and I think you and others detailed some of the consequences of the loss of capacity and capability. So that's a point I think that we all ought to bear in mind even as we talk about this subject and some of the specific programs.
Right, and I would hope to that the department also would at least provide for us some additional statements of priority and strategic planning as to what would happen if resources became available based on your experience of looking at what took place with the cuts and the devastation, what we need to do. I know you've set some goals as what you'd like for California's public health to look like, you know, knowing what we've done, where we are with regards to that, and where we need to really reinvest in order to get us moving in a direction, all things being good and equal, for the next few years. Obviously, we've done enough devastation that it's not going to be resolved this year. And I think we've said that over and over again. But if we have a vision as to where we want to go, and then it provides us with some support in addition to some of our own priorities as to what we think we need to reinvest in now, and at what level, and maybe what we need to continue to reinvest in the future in order to get us to where we want to go, all things being equal with resources being available. I think that would be helpful. We have a number of persons who are waiting to tell us some marvelous things, I gather. You'll have a minute to do it. What a long time. But I know you're eager to tell us, and so we're looking forward to it. Please come forward and be sure to give us your name and organization you represent.
Madam Chair, members, Jason Bryant, California Dental Association. I wanted to thank the panel earlier for its positive comments about the establishment of a state dental director. Not only would a dental director be a coordinator of multiple public health programs throughout the state, would be a point person also for pulling down federal dollars that California currently is missing out on and that other states are taking advantage of. So for those reasons, we would support the establishment of a state dental director. Thank you.
Thank you.
Good evening. My name is Peter Davidson. I'm an assistant professor in the Department of Medicine at the University of California, San Diego. My specialty is doing research on heroin-related overdose. I helped set up the San Francisco Department of Public Health's naloxone overdose prevention program in 2003, and I'm currently working with the San Diego Sheriff's Department to get San Diego Sheriff's deputies trained to carry naloxone. Naloxone is a well-established overdose prevention program. It's been demonstrated to statistically significantly reduce deaths in counties that have it. With respect to the drug overdose grant program proposed by Laura Thomas, I've been modelling how many lives would be saved if the $2 million proposed was spent. And based on this modelling, we could expect to see between 149 and 1,612 lives saved and families spared the incredible pain and high costs of losing a loved one over the next 3 years. If more money were available, say $10 million instead of $2, the model suggests we could expect between 830 and 8,900 lives to be saved in the next 3 years. I want to emphasise that this is just the direct lives saved. There's many other positive benefits of these programs. For example, drug users who are trained to give naloxone are statistically more likely to stop using drugs themselves in the next 12 months compared to drug users who don't receive this intervention. Thank you very much.
Thank you.
Committee members, my name is Loretta DeLastro. I'm from Ventura County, and I'm here representing a large national group, Broken No More, and also Not One More, and GRASP, which is Grief Recovery After Substance Passing. I am a bereaved mother. 3 years, 2 months, and 7 hours ago, my only son of 4 children succumbed to respiratory failure at home and died. He did not have naloxone. We were not trained on overdose awareness and prevention. We were white-knuckling it like a lot of families do, hoping that they do the right thing. He was returned from a brief period of recovery. After 11 months, he relapsed, and he died. But that's not why I'm here. I am here not to publicly mourn my son, but to say that, yes, I am a broken-hearted mother. But that is not unique. I'm an example of many, many women in our state, across the country. But I've turned a terrible tragedy into something very positive. I started to coordinate with other mothers who were like me. And through that work, and talking with other moms like me, we discovered that none of us knew about naloxone, none of us had overdose awareness training, and none of us knew that our children died a slow death of respiratory failure over the course of 1 to 3 hours. We all thought it was instantaneous, and it's not. The kind of work that I did, and I'll tell you about that in a moment, in my community, is something that anyone can do, and it can be duplicated. I'm just an average mom. I'm nothing special. I can convince you of the importance of investing in Assembly Bill 1535. This bill will bring breath to our children. It will bring life to our children and hope to our families. I work with thousands of families. Lil Austin, who was just 21. Josh Isaac, 19. Lindsay, 23. Countless beautiful kids in the prime of their life just stopped breathing because the part of the brain that lets us breathe was just shut off. This little box here was used to save a life. Because this was used, a girl is not in a permanent box. What I did was I tried to get people to help me, help the community before these kids die. And in doing so, I found an organization in Los Angeles who was willing to come to my home in Agora Hills, Oak Park area, to do a training. 20 people came to that training. Within 3 weeks of that training, 2 separate parents had an emergency at home and had to use their kits. This is one life saved right here.
May I ask you to sum up quickly?
Yes. If you can help us allocate this minimal investment for the terrible heroin and pill epidemic in California, help us with our grieving process. We're not cold numbers. There's people left behind. We can reduce overdose deaths in your communities and your constituencies for your state. We can have everyone have a complete family. Thank you so much for your time.
Thank you.
Good evening, Lisa White with the California School-Based Health Alliance. I'm here today to urge your consideration of the Public School Health Center Support Program. As included in your written materials, this program was created in 2006 but has never been funded. It was created to support the growing number of school-based health centers in California. Numerous studies have shown that when students have access to health care on their school campus, they are more likely to receive constant medical, behavioral health, and dental care, and are less likely to go to the emergency room or be hospitalized. Children served by California's school-based health centers live in many of the state's most distressed neighborhoods where children and families are uninsured, experience barriers to accessing preventative health care, have high rates of emergency room visits, obesity, asthma, and exposure to violence and trauma. School-based health centers are a smart investment. They reduce expensive health care costs and ensure kids are in school and ready to learn. Our organization looks forward to working with this committee in considering a state investment in school-based health centers. Additionally, our organization strongly supports a reinvestment in the Children's Dental Disease Prevention Program. This is an important and successful program in providing needed dental health care to kids in schools. Thank you.
Hi, Justin Garrett with the March of Dimes, here in strong support of restoring $3.9 million in funding for the Black Infant Health Program. Our mission is to reduce infant mortality and premature births, and we're encouraged by California's progress in reducing these rates. However, health disparities persist, particularly for Black infants, where the infant mortality rate is more than double the rate for all infants. The Black Infant Health Program is a vital public health program that works to address these high infant mortality rates, improve the lives of California families, and reduce health care costs. We've heard today about the positive impact it can have on our participants who are in the program, as well as the devastating impact the cuts to the program have had on staffing and the number of women served. So we're working with a large and diverse coalition of organizations to get this funding restored. Thank you for including it on the agenda today, and we look forward to continuing to work with you on this issue.
Thank you.
Holly Lane Bean on behalf of San Mateo County and the California Nurse Midwives Association, both in support of restoring the $3.9 million in state general funds for the Black Infant Health Program. Both organizations are part of the large coalition in support, and we believe that this would be a strong reinvestment, as you said, Assembly Member, that has lasting effects on both reducing health disparities and improving the health of these mothers and children, and we urge your support. Thank you.
Thank you.
Good evening, Chair, members. Tahira Cunningham with the California Pan-Ethnic Health Network. We're here for two issues today. School-based health center, we strongly support a real investment in this program. Communities of color are disproportionately impacted by a lack of access to health care services, particularly culturally competent, accessible services. School-based health centers are a proven model of going into the community, providing those culturally appropriate services, tailoring their services for the needs of the students and the communities, and are staffed by individuals who understand the experience of the youth, because they often have that same experience. So we encourage you to support the investment in that program. In regard to the Black Infant Health Program, it is a vital program that, when funded, really improves the health of African American mothers and their children, and fights to reduce disparities by empowering mothers to make better choices for themselves, healthier choices for themselves and their family. We appreciate your leadership in prioritizing this issue, and as our colleague said, we'll look forward to working with you. Thank you.
Good evening. My name is Arlene Cullum. I'm with Sutter Medical Center, Sacramento, and I'm here to urge you to restore funding for the California Adolescent Family Life Program. For the past 30 years, AFLP has touched and helped and guided the lives of thousands of teen parents and their children. With the state general fund cut of $10.7 million to the program in 09-10, it eliminated an additional $5.4 million in matching federal dollars that supported services for expecting and parenting teens to promote positive parenting outcomes, effective parenting, and positive socioeconomic independence. This totaled $16.1 million in reductions. So AFLP served 17,000 teens in 2008 in the state, and with the general fund cuts that occurred, now we serve only 6,000. There are large waiting lists. In Ventura County alone, there are 170 teens on the waiting list. This program is designed to enhance the health, social, economic, and educational well-being of pregnant and parenting adolescents and their children, and it builds on the case management model. And it uses a strength-based model to link services to these clients to promote positive pregnancy outcomes, effective parenting, reduce subsequent pregnancies, and developing independence. So, you know, what Mr. Chesbro said about you don't see what doesn't happen, that's exactly right when you look at affecting adolescent pregnancy. So I strongly urge you to consider the restoration. Thank you.
Madam Chair, members, Autumn Ogden with California Coverage and Health Initiatives, and we have 3 issue areas we wanted to address today. The first is the Black Infant Health Program. It is an amazing program with proven results, and for the low cost to the state, we think that it is one of the ones that should really be looked at for early restoration of funding. We would like to also address the D2P2 and the dental director and align our comments with Eileen Espejo, who spoke earlier, and just saying that we strongly believe that this is another area that should be considered. The dental director would provide needed guidance for the state. And then finally, on the Early Mental Health Initiative, we believe that restoring funding to this program would provide needed support to children by identifying a younger age mental illness that could be resolved early in their lives. Thank you.
Thank you.